Hello students, welcome to this video. So this is an integrated video with me and Dr. Meenakshi. So that means you're gonna do biochemistry as well as pediatrics in this video. See, normally how you study? When you study, you do basic subjects first, paraclinical subjects, which are a little boring, and then you move on to clinical. But now the pattern of questions are changed. More and more of clinical questions are asked. They are not like one-liners paraclinical subject questions. But in those clinical questions, you need to know some basics. So the new way of study is retrograde study, that with the clinical case in hand, first you read the clinical scenario and then moving on to the basic paraclinical subject. This way, your studies are interesting and the concepts are long-lasting. Okay, so Dr. Meenakshi will be starting each question in this video as these are clinical questions. Okay.
Hello friends. So let us move on straight to the MCQs that we are going to discuss today. Starting with the first question. So what we have here is a male child who presented with coarse facies, okay, coarseness of face, protuberant abdomen, okay, the abdomen was protuberant, there was enlargement of the head size, thickening of the cardiac valves was also there, thickening of the cardiac valve, hepatosplenomegaly and hearing impairment. However, there was no corneal opacity. What is the most probable diagnosis? Now, all these features that I've highlighted here, that is the coarseness of the facial features, okay? I'll show you a picture of the coarse facies, protuberant abdomen, which is mostly because of the hepatosplenomegaly and the lax abdominal wall, and these children may also even have inguinal hernias, enlargement of the head size, thickening of cardiac valve, hepatosplenomegaly. So everything, all these is showing that there is deposition of some substance in the body, okay? Excess deposition of glycosaminoglycans can cause this kind of a picture, which is seen in a group of disorders that is known as mucopolysaccharidosis, okay? Mucopolysaccharidosis. Now, mucopolysaccharidosis type 1 is called Hurler disease. But in Hurler disease, you also get corneal opacity because of the deposition of the glycosaminoglycans in the layers of cornea and disruption of the collagen, right? So, but here the question categorically says that there is no corneal opacity. So, the type of mucopolysaccharidosis with no corneal opacity is Hunter disease or type 2 mucopolysaccharidosis. Now, all types of mucopolysaccharidosis have what kind of inheritance? It has autosomal recessive inheritance, except type 2, which has X-linked recessive inheritance, right? So, I'm sure all of you would have guessed the answer to this question correctly. It is not Hurler disease because corneal opacity is not there, which is usually a very common feature of Hurler disease. Hunter disease seems to be the most plausible diagnosis here. Fragile X syndrome is a disorder where, there is intellectual disability. It is seen in males and they have, elongated face, large ears, large testes, and all that is there, okay? Tay-Sachs disease is another disorder. It is a storage disorder, but in that storage disorder, hepatosplenomegaly is usually not seen, right? So this mucopolysaccharidosis, as I told you, you have this deposition of glycosaminoglycans. Dr. Smily will be elucidating the various types of mucopolysaccharidosis, the enzymes deficient, and the substance which is deposited there. But remember, without corneal opacity, if it is there, it is Hunter disease mostly. And if there is corneal opacity, it will be type 1 MPS. And type 1 MPS has got a spectrum of clinical features, okay? So Hurler disease is the more severe phenotype of type 1, while Ski disease is a more milder phenotype, okay? And as I said, because of the deposition of glycosaminoglycans, you can get coarse facies, large head size, hepatosplenomegaly can be there, thickening of the cardiac valves can be there, airway obstruction can be there, right? You can have hepatosplenomegaly. So you can have all sorts of manifestations and they can have, myocardial dysfunction can be there, obstructive sleep apnea like changes can be there. And there can be even skeletal abnormalities in the form of dysostosis multiplex. Skeletal abnormalities, remember, is most commonly seen in which type of MPS? Yes. So skeletal abnormalities are most common in type 4 MPS or Morquio disease, right? Okay. So this is the example of the typical coarse facies that I was talking about. You can see there is some puffiness around the eyes, the prominence of the alae nasi, okay? And you can see that the prominent forehead is there, prominent tip of the nose is there, thick lips and thick tongue is there, macroglossia is there. So all these are features of this core species that we were talking about. Okay. So over to Dr. Smily to discuss the pathophysiology.
So as you're done with the clinical thing, so let's do this basic table of the enzyme involved in each mucopolysaccharidosis. Okay. So mainly we have type 1 and type 2, which are important and questions are asked. So type 1, which is Hurler disease, we can say it is type 1H, the subtype H, Hurler disease. This is autosomal recessive. The enzyme deficient is alpha L iduronidase, and the GAG, that is glycosaminoglycan, or the heteropolysaccharide which is accumulated is DS plus HS both. What is DS? It is dermatan sulfate, and HS is heparin sulfate. Okay, I have used the short forms here in the table. Then another subtype of type 1 is type 1S, that is also autosomal recessive. Most of the mucopolysaccaridosis are autosomal recessive, right? Now this is S stands for Shy's disease, Shy disease. Here also same enzyme alpha L iduronidase as it is type 1. And here only dermatan sulfate is accumulated. Okay. Due to heparin sulfate, patients have mental retardation. So in type 1S, there is no mental retardation. Okay. And corneal clouding occurs in all the mucopolysaccharidosis, right? Now, the next is MPS type 2. This is X-linked recessive. There are many features in Hunter's disease which are different from the other ones. So, Hunter disease is also having accumulation of DS, dermatan sulfate and HS. So, clinical features are quite similar to Hurler disease. And it is known as mild Hurler plus aggressive behavior. So the clinical features are milder in Hunter disease and the behavior of the child is more aggressive here, right? And there is no corneal clouding. There is no corneal clouding. So what is the mnemonic? The name is Hunter. Hunters are usually males. Hunters which go for hunting in the jungle, they are usually males and they should be having a clear vision. Okay. So type 2 is X-linked recessive, means mostly males are affected, and no corneal clouding means they have clear vision, right? What is the enzyme involved here? Enzyme is iduronate sulfatase. Enzyme is iduronate sulfatase. Okay. Then one more we can do, type 6. Type 6, which is also autosomal recessive. The disease is Merotto-Lamy syndrome. Merotto-Lamy syndrome. And the enzyme deficient is aryl sulfatase B, and the GAG accumulated is dermatan sulfate, right? Then let's also do 6 types of GAGs which we have, and their location is frequently asked. Okay, so the first one, hyaluronic acid, which is having no sulfate. Otherwise, all the GAGs have sulfate. It is present in synovial fluid and vitreous humor of the eyes. Okay. Then chondroitin sulfate present in cartilage, bone, tendon and ligament. Okay. Then keratin sulfate, which is present in cornea and connective tissue, and it is responsible for the transparency of cornea. This is frequently asked. Also, keratin sulfate has no uronic acid. Otherwise, all other GAGs have uronic acid in it, right? Then dermatan sulfate, very easy. Location is skin, blood vessels and valves. Okay. Then heparin, which is an anticoagulant. It is released from mast cells and liver. Then heparin sulfate, which is present on the cell surfaces. It has role in retinal cell-cell attachment, right? Or any cell-cell adhesion is done by heparin sulfate. Okay. Out of all the GAGs, which has highest negative charge is heparin. Highest negative charge, heparin, right? Then let's also do the difference between proteoglycan and glycoprotein. Heteropolysaccharides or GAGs are carbohydrates. They are carbohydrates. They attach with protein to make proteoglycan. So the other one is glycoprotein. Okay, both have protein plus carbohydrate, but the part which is written later, that is more in amount. Here glycan, carbohydrate, is more than protein. Here protein is more than carbohydrate. Okay, so in proteoglycan, carbohydrate is always a heteropolysaccharide, and carbohydrate here is long and linear. Example of proteoglycan is agrican and syndican. Agrican is the main proteoglycan of cartilage. In this, we have chondroitin sulfate plus protein. So, chondroitin sulfate is the main portion. Little of protein, it becomes a proteoglycan, that is agrican, right? On the other hand, let's do glycoprotein. Here, carbohydrate portion is either a monosaccharide or oligosaccharide and never a polysaccharide. Okay, it is never a polysaccharide. Then carbohydrate here is short and highly branched. Okay, it is short and branched. An example is the fibrous protein collagen. Fibrous protein collagen, it is mainly a protein, but some portion of carbohydrate is attached to it. So it becomes a glycoprotein, right?
Now moving on to the treatment of mucopolysaccharidosis, nowadays we have availability of enzyme replacement therapy, okay? We saw certain enzymes are deficient in different types of MPS like alpha-L iduronidase, right? Iduronate sulfatase and so on. So enzyme replacement therapy is now available for some types of MPS. For which types of MPS it is available? So it is now available for type 1, type 2 and type 6 MPS. That means for Hurler disease, for Hunter disease and for Maroteaux-Lamy disease, right? So for all these three types of MPS, there is enzyme replacement therapy, and with that there is, improvement in this hepatosplenomegaly and in certain aspects. But the neurological changes, intellectual disability, if it has set in, it does not show much improvement, right? And apart from the MPS types, enzyme replacement therapy is also available for some other important metabolic disorders like Pompe disease or type 2 glycogen storage disease, okay? It is also available for Gaucher disease, which is a very, very important lysosomal storage disease, and it is also available for Fabry disease. Now, apart from enzyme replacement therapy, hematopoietic stem cell transplantation is an option for treatment, and of course, there is need of multidisciplinary care. That means, there should be availability of, different specialities together to take care. Like there will be some orthopedic joint related problems. So that has to be taken care of by the orthopedics team. Cardiac problems, the cardiac team. Then obstructive sleep apnea. So you'll need ENT personnel and sleep pulmonary medicine personnel for that. So there has to be a wholesome treatment. So multidisciplinary treatment is what is required. But the quality of life of these patients is often not good, and the prognosis, of course, is guarded. Enzyme replacement therapy, even though it is available at few centers only and is very expensive as of now, right? So moving on to the next question. So what we have here is a 3-week-old baby girl who did not respond well to breastfeeding. So she's breastfeeding, but she is not, very comfortable with that, and developed recurrent vomiting, diarrhea, and conjugated hyperbilirubinemia, right? So conjugated hyperbilirubinemia, that means some liver dysfunction is there probably, right? Which is leading to this conjugated hyperbilirubinemia, vomiting, and there is also some diarrhea. She has failure to thrive. That means she's not gaining weight adequately, okay? On examination, she was found to have hepatomegaly. So liver is enlarged. Now, eye examination shows that there is no cherry red spot or chorioretinitis, right? But she had bilateral cataract. The deficiency of all of the following enzymes can be responsible for this patient's condition except. Yes, guys, so what do you think is the answer? Waiting for your answers. So, this characteristically appears to be a case of, very good. So, this appears to be a case of galactosemia, right? And why are we calling it galactosemia? Because this breastfed child is having conjugated hyperbilirubinemia, recurrent vomitings and diarrhea, failure to thrive, hepatosplenomegaly, and there is also bilateral cataracts. So all these features can be explained by this disorder galactosemia. which can be due to the deficiency of any of the three enzymes. Which three enzymes? Galactose 1-phosphate uridyl transferase, galactokinase, or epimerase. Any of these three enzyme deficiencies can cause galactosemia. Now, don't forget, my friends, to see the word except in the question, and don't jump to answer the question without reading all the options. Okay, don't jump and answer galactose 1-phosphate uridyl transferase. That is a very common mistake we make. We think we know the answer, we don't go through the options, and sometimes we miss the word except in our excitement. So don't do that, right? So the best answer here is glucose 6-phosphatase, because we know glucose 6-phosphatase is Bonn-Giacche disease, and here we are dealing with a scenario of galactosemia, right? Okay.
Now, as you're done with this clinical case of galactosemia, so let's do the basics of galactose metabolism. And here, three enzymes are involved. Okay. So let's have a look. When galactose enters in our body through diet, it is taken by first enzyme, galactokinase. In the cells, galactokinase will phosphorylate it and convert it to galactose 1-phosphate. Obviously, kinase enzyme, so ATP will be used, right? Then, galactose 1-phosphate is converted to UDP galactose. UDP galactose, this is second enzyme, and this enzyme is galactose 1-phosphate uridyl transferase, which is the rate-limiting enzyme of galactose metabolism. This enzyme is transferring uridyl group. It is transferring uridyl, that is UDP group, from UDP glucose, and UDP glucose gets converted to glucose 1-phosphate in this step, right? Then the third enzyme is UDP galactose is converted to UDP glucose by epimerase enzyme. Why epimerase? Because glucose and galactose are epimers of each other. They are epimers of each other at position number 4. So, complete name of enzyme is, take the name of substrate also, UDP galactose 4 epimerase. Okay. So, let's revise. What are the three enzymes involved in galactose metabolism? Galactokinase. Then next is GALT. Short form is GALT, galactose 1-phosphate uridyl transferase. Right. And then third is epimerase. Okay. Now, deficiency of this GALT leads to classical galactosemia. Classical galactosemia. If only galactosemia written means it is classical only. Whenever we write classical word in front of any disease, that means it is the most common type, right? So, in classical galactosemia, patient will be having cataract, oil drop cataract, and liver is affected and brain is affected because galactose 1-phosphate is getting accumulated, which gets accumulated in liver and brain, right? And why cataract is occurring? Because galactose gets converted to galactitol. Galactitol is responsible for this oil drop cataract. And the enzyme involved here is aldose reductase. Aldose reductase, right? Then it is an important point that galactose is required at many places in the body. That is glycolipids, glycoproteins, GAGs formation, and for lactose formation, for example, to make milk in a lactating mother, right? So galactose is required in the body. But in a patient with galactosemia, we restrict galactose in the diet and galactose can be easily formed in the body. So galactose is not essential in diet. How? Because epimerase reaction is reversible. See, we easily have glucose in our cells. Glucose will be converted to glucose 1-phosphate. Glucose 1-phosphate can be converted to UDP glucose. And now by epimerase enzyme, glucose can be converted to galactose, UDP galactose, which can be utilized in body wherever required. So it is not necessary to take galactose in diet.
So moving on to the treatment of galactosemia. So, we have to eliminate galactose from diet. And we know lactose contains glucose and galactose. So we have to eliminate lactose from the diet. Now milk is the most important source of lactose that we have. So we have to stop that. Okay. So we have to, the milk intake should be stopped, and even breast milk is contraindicated in a child with confirmed galactosemia. Okay. So if galactosemia is confirmed, then all galactose containing food items should be removed from diet. Okay. Food items stopped. So including breast milk. So galactosemia is one of the very few contraindications of breastfeeding. Okay, very important for you to remember. So including breast milk. Now, if you eliminate this galactose from diet, then usually the clinical features are going to improve. Okay, the hepatic dysfunction will improve. The child will have, normal intelligence. There will be weight gain and everything will be there. Plus, you need to give calcium and other supplements as well. Right? So, moving ahead to the next question. So again, we have a case scenario. Now, don't get bogged down by these case scenarios. So these are testing some very basic concepts, but how you apply the knowledge that you have, that is very important, right? So a 3-year-old boy was brought to the emergency department after several episodes of vomiting and lethargy, right? He was also found to have hypoglycemia, right? His pediatrician was concerned about possible hepatic failure along with recurrent episodes of vomiting and lethargy. A detailed counseling of the parents revealed that the symptoms appear every time after the ingestion of sweets or fruits. What is the most likely diagnosis? Now, this definitely seems to be a metabolic disorder where you have a child with vomiting, lethargy, episodes of hypoglycemia, and this is episodic illness, and this is precipitated mainly on taking sweets or fruits. So what do you think is the most appropriate answer for this question? Yes? Waiting for your answers? Very good. So this appears to be a case of hereditary fructose intolerance, right? Because, it is mentioned that these symptoms typically appear on taking sweets or fructose. Sweets will contain sugar. Sugar means sucrose, right? And sucrose consists of glucose and fructose. Now, in hereditary fructose intolerance, Dr. Smily will be telling us more about the, biochemical basis. But as we can make out from the name itself that the patient will not be able to digest fructose and will have manifestations because of that. There will be hepatic dysfunction, and because of hepatic failure, you'll have jaundice can be there, hypoglycemia can be there, vomiting, lethargy, and so on can be there, right? And in these children, you may even get a history that the parents will say that these children have aversion to sweet food. That means they do not like to eat sweet food. This happens because, these children, whenever they take sweet food, they have these symptoms of vomiting, diarrhea, pain abdomen, and so on. So they learn that whenever they will take sweet food, they will have these symptoms. So they start avoiding sweet food. So typically in case scenarios, you can even get a history that the child has aversion to sweet food. Okay. In that case, we think of hereditary fructose intolerance. Glycogen storage disease type 3 will not have such a presentation. So Cori disease, it can present with hypoglycemia can be there, hepatomegaly, but muscle involvement can also be there. Okay. So this does not seem to be the typical case scenario, and it will not get precipitated by the intake of this fructose or, sweet foods and so on. Galactosemia, we already saw what is the typical presentation. Fructose urea is a very benign kind of a condition where if excess fructose is taken in the diet, fructose will be excreted in urine. So this condition remains asymptomatic and it is a totally benign condition. Nothing needs to be done about it. So over to Dr. Smily to discuss the biochemical basis.
Okay, so you are done with this clinical case of hereditary fructose intolerance. So let's see the basic fructose metabolism. So in fructose metabolism, when fructose enters the cells, the first step will be its phosphorylation and ATP will be used here. ATP used, okay. Enzyme is kinase and we get fructose 1-phosphate. This fructose 1-phosphate will be taken by enzyme aldolase B. So what is the substrate for aldolase B? It is fructose 1-phosphate. Can you tell me what is the substrate of aldolase A? Aldolase A, which we did in glycolysis, substrate is fructose 1,6-bisphosphate. Okay. Now here we have aldolase B in fructose metabolism, and this aldolase B will be broken down to glyceraldehyde and dihydroxyacetone phosphate, that is DHAB. Okay. Then third enzyme is kinase again. converting glyceraldehyde to its phosphorylated form, that is glyceraldehyde 3-phosphate. Okay. Both these are intermediates of glycolysis, so they will enter glycolysis and other enzymes of glycolysis will be used, right? Why fructose and galactose metabolisms are using enzymes of glycolysis? This is in order to save energy. Body will not make all the enzymes different for galactose and fructose. What body will do? Body will just convert galactose to glucose and enzymes of glycolysis can be used. And in case of fructose, body is converting fructose to intermediates of glycolysis and other enzymes of glycolysis will be used. So that body is not wasting energy in making all the enzymes different for galactose and fructose metabolism. Okay. So, deficiency of this aldolase B is hereditary fructose intolerance, where the substrate which is accumulated is fructose 1-phosphate. So, fructose 1-phosphate gets accumulated in liver, due to which it will cause jaundice, hepatomegaly, and it also is accumulated in kidneys. And if this disease is not treated, then kidney failure can occur. And also, in hereditary fructose intolerance, patients have fructose-induced hypoglycemia. That is, after intake of fructose, patients have hypoglycemia. Why? Because fructose 1-phosphate inhibits enzyme glycogen phosphorylase. It is inhibitor of rate-limiting enzyme of glycogen breakdown, that is glycogen phosphorylase. So, when this enzyme will not work, then liver's glycogen cannot be broken down. So, blood glucose will not be released from liver. So, this will lead to hypoglycemia, right? And if this first enzyme, fructokinase enzyme, is deficient, then this leads to essential fructose urea, which is a benign condition, right? There is one more thing occurring in hereditary fructose intolerance, that is sequestration of inorganic phosphate. What happens is that when there is accumulation of fructose 1-phosphate, too much of phosphate is joined with fructose, so we have less phosphate available in the cells. So this is known as sequestration of inorganic phosphate, which also occurs in von Gerk's disease, right? Now, due to this, what will happen? ATP production falls, because conversion of ADP to ATP, we require phosphate. So when phosphate is not there, ATP production falls, or we can say AMP levels are raised. When AMP is raised, excess of AMP will be degraded, leading to the formation of uric acid. So patients have hyperuricemia. And whenever patients have hyperuricemia, this will lead to lactic acidosis, because lactic acid and uric acid competes with each other for excretion by kidneys, right? And also decrease ATP in liver. This will lead to decreased gluconeogenesis, because gluconeogenesis also requires ATPs. Gluconeogenesis, to make 1 glucose, we require 4 ATPs and 2 GTPs, right? So this will also lead to hypoglycemia, because gluconeogenesis will not occur, right? And this thing I already told you, that fructose 1-phosphate inhibits glycogenolysis, leading to hypoglycemia, right? Then we can do the differences between aldolase A, B and C. Aldolase A is present in most tissues, and this is the enzyme involved in glycolysis in most tissues. And the reaction is cleavage of fructose 1,6-bisphosphate to DHAP and glyceraldehyde 3-phosphate. Okay. In case of aldolase B, which is for fructose metabolism, it is only present in liver, kidneys and small intestine. This aldolase B will cause cleavage of fructose 1-phosphate into DHAP and glyceraldehyde, right? We already did that. Then aldolase C is a special enzyme present in brain, and it will do the same reaction as aldolase A. fructose 1,6-bisphosphate into DHAP and dysraldehyde 3-phosphate, right?
Thank you, Dr. Smiley. So moving on to the treatment of hereditary fructose intolerance. So as we already said that these children cannot digest fructose. So what we have to do is we have to stop fructose from the diet. So stop fructose from the diet. Okay, stop fructose in any form in diet. And in the acute episode, when the child is having hypoglycemia, at that time you have to use IV glucose or dextrose to correct the hypoglycemia. You have to give IV fluids to correct the acidosis. And if there is hepatic dysfunction, we also need supportive therapy for treating the hepatic dysfunction, right? Now, apart from that, when the child improves, lifelong the child has to have a fructose-free diet. So it has to be so stringently followed that, most of the cough syrups and some other syrup medications that we take are sweet in taste and they contain this sucrose and fructose. So even that should be avoided if possible. And if possible, these children should be given crushed tablets instead of syrups. So it is so important to eliminate fructose from diet for them, right? So moving on to the next question, what we have here is a child who presents with a history of irritability is there and there is developmental delay, right? Developmental delay and urine with burnt sugar odor has been brought to pediatrics OPD. Excess of all of the following amino acids can be tested in the urine of this child except. Now, what do you think is the disorder that this child is suffering from? Yes? Anyone? So the clues that we have here are, there are some CNS manifestations. There's some degree of encephalopathy that is there. There is irritability. There's some intellectual disability or developmental delay that is there. And you have urine with burnt sugar odor that is typically seen in which disorder? Yes, you're right. It is seen in maple syrup urine disease, where you have a urine odor which is burnt sugar kind of or maple syrup kind of odor. Now, maple syrup urine disease, Dr. Smiley will be discussing more about the biochemical basis, but we know that there is, problem in the metabolism of the branch chain amino acids, that is isoleucine, leucine and valine. So they are going to be in excess amount in blood as well as urine. So the question says excess of the following amino acids can be tested in the urine of this child except. So don't forget to see the word except again. So leucine will be there in excess, isoleucine will be there in excess and again valine also, but not phenylalanine. So the answer to this question is very good. It is phenylalanine, right? So maple syrup disease, urine disease is a disorder where you get typical odor. Similarly, there are some other inborn errors of metabolism where the urine of the baby or the cerumen or even the sweat of the baby gives a typical odor when you go near to the baby. So what are some of the IEMs which have a typical odor in the body fluids? So one we said is maple syrup urine disease where you have a maple syrup or a burnt sugar odor. Okay, maple syrup or burnt sugar odor. Then you have in phenylketonuria, you have a mousy or musty kind of a body odor. Okay, so phenylketonuria, there is a mousy or musty body odor. Okay, due to the accumulation of the metabolites. You get a boiled cabbage kind of a body odor in tyrosinaemia. So tyrosinaemia. So these are some very few examples. Tyrosinaemia, you have a boiled cabbage kind of a odor. You get a sweaty feet odor in glutaric aciduria. Okay. So sweaty feet odor is something that you get in glutaric aciduria. Glutaric aciduria. And even in isovaleric acidemia, you can get sweaty feet odor. So there is another type of odor that is called tomcat urine odor that you get in multiple carboxylase deficiency. So in multiple carboxylase deficiency, you can get a tomcat urine odor, right? So these are some specific IEMs where you can get some peculiar body odor. Now coming back to this maple syrup urine disease. What we said is because there is, accumulation of these branch chain amino acids, especially leucine. So there are high levels of leucine which will enter the, the CNS and will cause encephalopathy. Okay, so there is encephalopathy, varying degrees of encephalopathy. So the child will have lethargy, poor feeding, can even have coma. Okay. So lethargy and poor feeding will be there. So that is because the leucine is not letting the other important amino acids reach the CNS. and high levels of leucine are also giving rise to this manifestation. So there is encephalopathy. Apart from that, there are some other CNS manifestations as well. There can be hypertonia, the tone of the body is increased, and there can even be opistotonic posturing or arching of back like you get in tetanus. Okay, so there can be this opistotonic posturing. Now, apart from that, there can be alternate bouts of flaccidity and increased tone. So there can be some boxing or cycling kind of movements can be there. Boxing or cycling movements. There can be seizures. Okay, seizures can be there. And characteristically, there is a hypoglycemia. Now, what happens if there is a hypoglycemic seizure or encephalopathy? As soon as you give dextrose or glucose, the clinical feature improves. But in this case, in maple syrup urine disease, you are getting hypoglycemia, you are correcting it with giving IV glucose, still the clinical features persist. Then you think of this maple syrup urine disease. Okay, so hypoglycemia and will be there and clinical features persist. This is very important clinical clue that clinical features persist even after correction of blood glucose. Okay, even after blood glucose correction, right? And of course, there can be ketoacidosis as well. So these are the clinical features of maple syrup urine disease. Now over to Dr. Smily to discuss the biochemical basis and the investigation findings.
So MSUD, maple syrup urine disease, involves branch chain amino acids. Branch chain amino acids are valine, leucine and isoleucine. You can see their side chain has a branch. These are also called aliphatic amino acids, and all the aliphatic amino acids are non-polar. And these three branch chain amino acids all are essential in diet. Body cannot synthesize these three and they are essential in diet. And these are very, very important for brain. So, any disease involving branch chain amino acids will lead to mental retardation and brain is affected, right? Now, let's see the biochemical reaction which is affected in case of MSUD. So, this MSUD is defect in the catabolism. It is defect in the catabolism of branch chain amino acids. Okay. So, usually for any amino acid, what is the first step in catabolism? We all know that first step in catabolism is transamination. Transamination, which requires vitamin B6. Vitamin B6 is required. These are reversible reactions, right? We all know transamination reactions. So, from amino acid, amino group will be removed and we will be left with keto acid, branch chain keto acid. Okay, this is the first step. Now, in branch chain amino acid catabolism, the second step is a step of oxidative decarboxylation. Oxidative decarboxylation. Any step of oxidative decarboxylation requires vitamin B1. Okay. So, whatever product is formed here, there is no need to learn that. Just concentrate on this second step. So, this step is oxidative decarboxylation step, and we all know that the enzyme of oxidative decarboxylation is a dehydrogenase. So, enzyme will be branch chain keto acid dehydrogenase. Branch chain keto acid dehydrogenase, or we can also call it decarboxylase. Okay. And this is a multi-enzyme complex. This is a multi-enzyme complex. In MSUD, this step is defective. This step is not occurring. So, which substrate will accumulate? Branch chain keto acid will accumulate, and also branch chain amino acid will accumulate. So, in serum and urine of these patients, there will be raised branch chain amino acids and keto acids, and because keto acids are raised, so patient will be having ketosis. Okay, keto acids, so ketosis. I already told you that brain will also be affected.
So moving on to the treatment of maple syrup urine disease. So in the acute stage, okay, so in the acute stage when there is encephalopathy, so acute stage, what all you need to do? We have to start IV fluids, okay, start IV fluids. So hydration is very important, and you have to remove the branch chain amino acids that have accumulated in the body, especially leucine. And you know, leucine is not easily excreted from kidney. So you may even have to resort to hemodialysis to remove it. So removal or clearance of branch chain amino acids from the body. Right? And for that, even hemodialysis may be required. And you need to provide sufficient calories. Sufficient calories have to be provided. So, sufficient calories and nutrition have to be provided either IV, intravenous or orally if the patient is able to take. So, sufficient calories and nutrition needs to be provided. And if there is evidence of cerebral edema, then you need to treat it using mannitol or hypertonic saline. So if cerebral edema present, then you have to use mannitol or hypertonic saline. Mannitol or hypertonic saline. Right? And after recovery, you have to use a diet which is low in branch chain amino acids. Now remember, this isoleucine, leucine, valine, all are essential amino acids. So they cannot be synthesized in the body. So you cannot give a diet in which, you know, these amino acids are totally absent, we cannot give, okay? So after recovery, you will switch to a special diets are available. So diet low in branch chain amino acids. And that has to be continued lifelong. And in some cases, even liver transplantation may be required, okay? So that is about the management of maple syrup urine disease. A very, very important topic. So what we have here, friends, is that the parents of a 5-year-old child, boy, who are a first-degree consanguineous couple. Now, wherever you're getting a history of consanguinity, remember there are increased risk of genetic or inherited disorders like inborn errors of metabolism, right? Accidentally noticed, okay, that the urine of the child turned black. So urine turned black when it was left standing in the air. So some bells should ring in your ear. So what do you think is the disorder the child is suffering from? Let's complete the question. They went to the family physician to seek advice on this, and further counseling revealed that the child has no other medical problems, right? With normal childhood growth and development. So what are we dealing with? His sibling is also normal. The physician should order a test of which of the following compounds in this patient's urine. I'm sure by now you've guessed what is the diagnosis. Yes? Come on. Very right. So the diagnosis is Alkaptonuria, right? Where you have deficiency of this homogentisic acid oxidase, and the substance that will accumulate in the blood and urine of this child is homogentisate, not methylmalonate or phenylpyruvate or homocysteine. So Dr. Smily will be discussing more about the biochemical basis of Alkaptonuria. But before that, I'll just mention briefly about the clinical features. So what we have here is this deposition of this homogentisic acid, which is giving the black color to the urine. So in children, so we only get this homogentisic acid which is excreted in excess amount in urine. So urine turns black on standing. So that is usually the only manifestation that we get during childhood. Now, during adulthood, you can get some more manifestations of Alkaptonuria, like, this excess deposition of the polymers of homogentisic acid can give rise to some black or dark colored spots on the sclera of the eye, on the ear cartilage, and even it can be deposited in the joints, causing arthritis. So the deposition of polymers of homogentisic acid, which is black in color, is known as ochronosis. Ochronosis. Okay? And it is mainly seen in the sclera of the eye and the ear cartilage. And there is deposition in the joints also, which leads to arthritis. And it typically has a osteoarthritis kind of a picture even on the imaging, on the x-rays, right? Now, apart from that, there can be sometimes deposition in the cardiac valves as well. Some degree of valvulitis might be there, okay? But these manifestations are seen in adulthood only, right? So this is what you can get pictures like this, where the urine you can see has turned black or dark in color on standing, right? And you can see these bluish areas or dark colored blackish areas in the ear cartilage and on the sclera. So that is what is ochronosis. And we said you can get an osteoarthritis like picture, and there can even be this calcification of intervertebral discs that you can see here, right? So over to Dr. Smily to discuss the biochemical basis.
So you have seen this case of Alkaptonuria. So let's do the catabolism of phenylalanine and tyrosine pathway where this enzyme is involved. Okay. So let's start. Phenylalanine gets converted to tyrosine. We all know the enzyme is phenylalanine hydroxylase, and defect in this enzyme is phenylketonuria. Okay. Then tyrosine gets converted to para-hydroxyphenyl pyruvate, that is PHPP. Here the enzyme is tyrosine transaminase. Okay. Transaminase is the first step in the catabolism. Okay. So first this amino acid phenylalanine, which is essential, that is converted to this non-essential amino acid tyrosine. So this tyrosine is used up for various functions in the body like formation of melanin, catecholamines, thyroid hormones, right? And then it is getting catabolized. So in catabolism, the first enzyme is tyrosine transaminase or aminotransferase, which requires vitamin B6, and we get PHPP. Now defect in this enzyme, tyrosine transaminase, leads to type 2 tyrosinemia. Okay. Then PHPP gets converted to homogentisate. Enzyme is PHPP hydroxylase, which requires vitamin C. This complete deficiency of PHPP hydroxylase is type 3 tyrosinemia, and partial deficiency of PHPP hydroxylase is Hawkinsinuria. In Hawkinsinuria, patients have swimming pool-like odor. Okay. Then homogentisate gets converted to mallyl acetoacetate. Enzyme is homogentisate dioxygenase or homogentisate oxidase. Homogentisate oxidase. This is the enzyme which is deficient in Alkaptonuria. So in Alkaptonuria, which substrate is getting accumulated? Homogentisate is getting accumulated, and this oxidation of homogentisic acid leads to blackening of the urine. And over years, homogentisic acid gets polymerized in body. In body, over years, it gets polymerized, leading to the formation of alkapton bodies, which gets accumulated in connective tissues, giving bluish-black discoloration, right? Then, mallyl acetoacetate gets converted to fumaryl acetoacetate, and enzyme is isomerase, okay? Then next is enzyme fumaryl acetoacetate hydrolase. Hydrolase enzyme. This defect in this enzyme is type 1 tyrosinemia. This hydrolase enzyme is breaking fumaryl acetoacetate into fumarate and acetoacetate. Because these two amino acids, phenylalanine and tyrosine, are making fumarate in the end, which is a TCA intermediate, so that's why they are called glucogenic. But they are also forming a ketone body, acetoacetate, in the end, so they are also ketogenic. So phenylalanine and tyrosine are in both category, that is both glucogenic and ketogenic. Okay. Then you should be clearly distinguishing between homogentisate and homocysteine. Okay. Homogentisate is involved in the catabolism of phenylalanine and tyrosine, and it is accumulated in Alkaptonuria, right? But on the other hand, homocysteine is involved in methionine metabolism. It is involved in methionine metabolism, and this compound is accumulated in homocysteine urea. Okay. So be careful between homogentisate and homocysteine. Now let's also do Garud's tetrad. There are 4 diseases in Garud's tetrad grouped together because these all were discovered by the scientist named Garud. So the mnemonic is CAP, CAAP cap. C for cystinuria. Cystinuria. A for Alkaptonuria. Alkaptonuria. Then next A is albinism. Then P is pentose urea. Essential pentose urea. Okay.
So the management of Alkaptonuria involves, so there is use of a drug which is known as nitisinone. So nitisinone is a drug that can be used, and this drug reduces homogentisic acid production. Okay, it will eventually reduce the production of homogentisic acid. Okay. Now, apart from that, you also need to give a diet which is restricted in phenylalanine and tyrosine, because ultimately you would have seen, like as Dr. Smily told you, that all this homogentisic acid is a byproduct or a metabolite of the phenylalanine metabolism pathway. Okay. So if you give excess of phenylalanine and tyrosine, more of homogentisic acid is going to be formed, right? So you have to use a phenylalanine and tyrosine restricted diet. Phenylalanine and tyrosine restricted diet. And apart from that, symptomatic management. So for arthritis, you have to do symptomatic management. That means use of NSAIDs, physiotherapy, and so on. So symptomatic treatment for arthritis, right? So that is the management of Alkaptonuria. So moving on to our next question, we have a 6-year-old boy who experienced episodes where he developed patches of skin rashes, which go away in a week to 10 days. So it lasts for a week to 10 days. And a pediatrician told the boy's parents to give him niacin the next time this will occur and give a high protein diet, and the rash resolved in a day or two. Right? The child has one of the following diseases based on this information. So what do you think is the disorder this child is suffering from? Is it cystinuria, Hartnup disease, HHS syndrome? So what is HHS syndrome? Hyperammonemia, hyperornithinemia, and homocitrullinemia syndrome, a type of urea cycle disorder, or Alkaptonuria. So guys, what do you think is the correct answer, best answer to this? Come on, waiting for your answers. So of course, we know this is not Alkaptonuria. We already saw a case of Alkaptonuria. Now in cystinuria, there is renal dysfunction, loin pain is there, hematuria can be there, okay, renal colic can be there. So cystinuria is typically not what will present with these skin rashes, right? Now HHH syndrome again is a urea cycle disorder, so that will present more with episodes of lethargy, and there can be hepatic dysfunction, and there can be vomitings and poor feeding and so on can be there. So it is typically not the presentation with skin rashes, right? So Hartnup disease is the best answer to this question, like most of you have guessed correctly, right? So Hartnup disease will not go into the biochemical basis, so that Dr. Smily will be discussing. But what we need to know is most children with Hartnup disease remain totally asymptomatic. Most children remain asymptomatic. Now, out of those who are having symptoms, the most common symptom is a skin rash, photosensitive, cutaneous photosensitivity. So out of the symptoms, the most common is cutaneous photosensitivity, right? So there is a pellagra-like rash that is there, okay? So this rash involves the area around the neck, and it involves the exposed parts, the sun-exposed parts of the body like the arms and legs, okay? And this cutaneous photosensitivity typically improves with administration of niacin. So this is typical of Hartnup disease. Over to Dr. Smily to discuss the pathophysiology and biochemical basis.
So Hartnup disease is an amino acid transporter defect. What is this transporter defect? There is a transporter present in intestine and kidneys. In intestine, it is for the absorption of amino acids. In kidneys, it is for the reabsorption of amino acids. So this transporter is for neutral amino acids. Neutral amino acids, especially tryptophan. So this transporter is defective in Hartnup's disease. That's why tryptophan is coming in urine. So we say that tryptophan is coming in urine, that is amino acid urea, without a corresponding rise in serum tryptophan levels, right? because reabsorption is not happening from kidneys. Okay. Then, so this is one transporter defect. Another transporter defect is Glycine Urea. So this is a transporter for glycine and proline which is defective. That's why glycine is the main amino acid which is coming in urine here without a corresponding rise in serum glycine levels, right? Then third is Cysteine Urea. In the Cysteine Urea, the transporter which is defective is for cysteine, the sulfur containing amino acid, and basic amino acids. So the amino acids which are coming in urine are cysteine, arginine, lysine, because arginine and lysine are basic amino acids, and also ornithine. Okay, and this ornithine is coming from arginine because arginine is the source of ornithine. Out of all the transporter defects, Cysteine Urea is most common. Okay, now tryptophan forms niacin. Niacin is vitamin B3 because it can be formed in body. That's why it is called an atypical vitamin. Otherwise, vitamins cannot be formed in body. Okay, so this amino acid tryptophan is making niacin. You need to learn that 60 milligram of tryptophan will make 1 milligram of niacin. The rate limiting enzyme in this pathway is QPRTase. QPRTase is quinolate phosphoribosyl transferase. Quinolate phosphoribosyl transferase, right? And here in this pathway, vitamin B2 and B6 are involved. So, can I say that B2 or B6 deficiency will also lead to pellagra, that is B3 deficiency, right? So, most of the B complex vitamins are interlinked. That's why in the treatment, they all are given usually together.
So, treatment of heart nerve disease, we've already mentioned that we have to give niacin or nicotinic acid and also a high protein diet. Okay. With that, these individuals do very well. Right? So moving on to our next question, this is a pretty straightforward question. So what we have here is an image-based question where the question asks that this is due to deficiency of. So this is the picture typically of a lip and there is some lesion at the angle of the mouth. Okay. So that is basically known as angular cheilitis. So this is a lesion that is called angular cheilitis. So this angular cheilitis or angular stomatitis also sometimes it is called. It is due to deficiency of which vitamin? I'm sure all of you know it. So nowadays you're getting lots of questions about vitamin deficiencies. So do read them up. So yes, which vitamin deficiency causes this angular cheilitis or stomatitis most commonly? Very good. It is vitamin B2 or riboflavin. Vitamin B1 or thiamine we know causes beriberi, deficiency will cause beriberi, niacin deficiency leads to pellagra, and B12 deficiency will lead to subacute combined degeneration of spinal cord and some other neurological manifestations as well as anemia, the macrocytic megaloblastic anemia, right? So this riboflavin deficiency that we are talking about here, riboflavin deficiency also gives rise to some other features. Apart from angular cheilitis or stomatitis, it gives rise to glossitis or a smooth tongue. Okay, smooth red beefy tongue can be there. You can have some seborrheic dermatitis. Okay, seborrheic dermatitis can be there. There can be some eye abnormalities like corneal vascularization, keratitis, conjunctivitis, photophobia. So there can be some eye involvement in the form of corneal vascularization, keratitis, conjunctivitis, photophobia can be there. Then there can be anemia, okay, and there can be generalized weakness. So many clinical features apart from, of course, this angular cheilitis or stomatitis is possible in this riboflavin deficiency, right? Over to Dr. Smily for some more information about this riboflavin deficiency and how to pick it up.
Now, let's also see some other biochemical roles of vitamin B2, that is riboflavin. So, mainly it has a coenzyme role required for many enzymes. So, which are these enzymes? One is the enzyme of link reaction PDH. pyruvate dehydrogenase. Then in TCA cycle, succinate dehydrogenase, and also alpha ketoglutarate dehydrogenase requires vitamin B2, and also branch chain amino acid dehydrogenase, right? So these enzymes requires vitamin B2 as a coenzyme. Then also you need to learn the marker enzyme for B2 deficiency. Frequently asked. Marker enzyme is RBC glutathione reductase activity. Not the quantity of enzyme, but the activity of this enzyme. Because this glutathione reductase, which is involved in RBCs, that also requires vitamin B2, right?
So the treatment of riboflavin deficiency is pretty simple. So what you have to do is you have to supplement riboflavin at a dose of 5 to 15 mg per day till the findings improve. So we usually give it in the form of a multivitamin syrup or tablet, right? And you have to encourage them to take a diet which is rich in riboflavin or B complex vitamin. Like, if they are vegetarian, they can take more of dairy products and legumes can be there. Okay, and mushrooms, they are said to be rich in this vitamin B complex. And of course, the non-vegetarian food items like meat and poultry items again are very important. Okay, so moving on to the next question. So what we have here is a 14-year-old child who presented to the doctor's camp with a 10 days history of well-defined skin changes that consist of symmetrical pigmented rash around the neck and upper trunk region. Okay, and limbs with soreness of mouth as well. Now the lesions progressively increased in size, and there is some itching, burning following exposure to sun. So there's some photosensitivity as well. Now apart from that, there was a history of diarrhea, but there is no change in behavior. There was no history of tuberculosis treatment in the family, or similar disease in the family. Her dietary history revealed decreased food intake after the cyclone Amphan, so a natural calamity, with a persistent consumption of maize. So that is a very, very important point that needs to be highlighted. So persistent consumption of maize is there, which is the basic meal in the household. So what is highly susceptible in this girl? So very, very important. So this is giving you a case scenario. This is such a big case scenario. It will take time for you to read, but you have to be very important to pick up the most important points. So you have to be very vigilant for that, right? So you can see that there is persistent consumption of maize, which is an important point here. And you have these skin changes around the neck and the upper trunk region and the limbs. And there is a history of diarrhea as well. But there is no history of any drug intake. So what are we dealing with? Yes? What do you think, guys? So again, this is a very, very simple question. At the outset, it might look big and gigantic, but if you read it and if you pick up the important points, it's so simple. So this is typically a case of pellagra, which is again due to niacin deficiency. So scurvy will not present like this. Scurvy is vitamin C deficiency where, impaired collagen synthesis is there. It presents with bleeding gums, painful subperiosteal hemorrhage or painful pseudo-paralysis of the limbs will be there in scurvy. Kwashiorkor is a protein energy malnutrition with edema. And beriberi again is thiamine deficiency, which can present with wet beriberi or cardiac failure, dry beriberi or neurological features. But this, friends, is typically the case scenario of pellagra. So in pellagra, you can get a rash like this, which is called Casal's necklace around the neck area. So like this, you can get this rash in pellagra, and we also saw similar rash in Hartnum disease. So pellagra is a disease of some Ds where you have this. What all is there? So you have dermatitis. So this is photosensitive dermatitis. The skin will become red and rough on exposure to sun. There can be itching as well. So dermatitis is there. There is diarrhea. In older patients, there can even be dementia, and it can even lead to death in severe cases. Okay. So over to Dr. Smiley to discuss a little bit more about it.
This question is also saying that the patient is mainly taking maize in his diet. So what is the concept here? Maize protein zein, it lacks tryptophan. And we know that tryptophan makes niacin. So deficiency of tryptophan leads to pellagra. Let's see other causes of pellagra also. Antitubercular drug isoniazid, it inhibits the formation of PLP, that is pyridoxal phosphate, which is the active form of vitamin B6. I already told you in one of the previous questions that in tryptophan to niacin conversion, vitamin B6 is required. So isoniazid also leads to pellagra. Then Carcinoid Syndrome, which is a tumor of carcinoid cells making lots of serotonin. So tryptophan is used up in the formation of lots of serotonin. That less of tryptophan is available for niacin formation, leading to pellagra. Then Hartnupp's disease, which we have already done. Okay, so these are other causes of pellagra.
So the treatment of pellagra we all know is supplementation of niacin. So you have to give niacin supplementation, and during the acute phase, you have to avoid sun exposure. Okay, and some soothing agents can be applied on the skin. So acute phase, avoid sun exposure, right? And the nutrition needs to be properly maintained. Okay, so that has also to be taken care of, right? So moving ahead to the next question, what we have here is a 3-year-old child who presents with massive hepatomegaly, okay, doll-like facies and hypoglycemia. There is no improvement of blood sugar even after administration of glucagon. What are we dealing with? So friends, I'm sure you are able to synthesize this information and come to the right answer. Yes. So this is a revision session. Come on, I want answer from you all. Yes, very good. So this is typically a case of Vaughan-Jarecki disease or type 1 glycogen storage disorder where you have glucose 6-phosphatase deficiency, right? So Anderson disease will not present like this. Anderson disease is the branching enzyme deficiency where you can get more of hepatosplenomegaly and features of hepatic failure, hepatic dysfunction can be there. There can be some bit of muscle involvement as well, okay? Pompe's disease is again typically the type 2 glycogen storage disorder where you have, involvement of skeletal muscles and cardiac muscles are involved. It can have an infantile form and a juvenile form can be there. And there is severe hypertrophic cardiomyopathy is there, hepatomegaly, and the child can be very sick, especially in the infantile form. McArdle disease is the most common glycogen storage disorder to present among adolescents and adults, and it usually presents with muscle features. So there can be muscle cramps, there can be even rhabdomyolysis giving rise to this myoglobin urea can be there, okay? And it has an episodic kind of a presentation. So typically in the given case scenario, the massive hepatomegaly that is mentioned, the doll-like facies and hypoglycemia, all these point towards a diagnosis of Vaughan-Jarecki disease. And in this, the hypoglycemia doesn't even improve on giving glucagon. Dr. Smily will be discussing more about why it happens and the biochemical basis. So in Vaughan-Jarecki disease, we said there is a deficiency of this glucose 6-phosphatase. So the clinical features that we're talking about, the child will have, even you'll see there will be hyperlipidemia giving rise to the doll-like facies. You can have massive hepatomegaly, so the abdomen will be hugely distended. So massive hepatomegaly. Even there can be increase in the size of kidneys can be there. Spleen is usually normal in size, and so muscles are also usually not involved in Vaughan-Jarecki disease. So you can get renal enlargement, okay? And there is this hyperuricemia, which can give rise to gout-like features and joint pain and so on. So hyperuricemia, lactic acidosis is also there. Okay, so a lot of metabolic disturbances are there in this Vaughan-Jarecki disease. So over to Dr. Smily for discussing more about the pathophysiology and the biochemical basis of this very, very important disorder.
So let's see the enzyme which is deficient in Vaughan-Jarecki disease. Vaughan-Jarecki disease mainly affecting liver. In liver, glucose 6-phosphate is converted to glucose by the help of enzyme glucose 6-phosphatase. Glucose 6-phosphatase. So suppose this is liver cell and glucose is getting formed here by this reaction. This glucose can come out of the liver cell in blood, giving blood glucose during fasting, right? Now, when this enzyme is absent in Vaughan-Jarecki disease, then what will happen? That this blood glucose is not released. So patients have hypoglycemia. These patients have severe hypoglycemia because gluconeogenesis also cannot occur and glycogenolysis also cannot occur, right? So severe hypoglycemia and ketosis. So body is not getting glucose, so body cells will think that we are in fasting, okay, because they are not getting glucose. But in liver cell, what is happening? This reaction not occurring. So the substrate which is getting accumulated is glucose 6-phosphate getting accumulated. So liver cell has lots of glucose. So liver cell will think that I am in fed state. So it's a confusion in body. Body cells, peripheral cells are thinking that we are in fasting, but liver cell is thinking that we are in fed state. So what will happen? Liver will convert this excess glucose to glycogen. There is excessive glycogen accumulation happening in this disease. Over years, this leads to hepatomegaly, and these patients have massive hepatomegaly, right? But spleen is not enlarged, and it is seen that kidneys are enlarged in these patients, again due to glycogen deposition in kidneys, right? Then excess glucose will be going into glycolysis also, making lots of pyruvate. Pyruvate will make lots of lactate. So this will lead to lactic acidosis in these patients. Excess lactate leading to lactic acidosis. Then pyruvate will be converted to acetyl-CoA. Acetyl-CoA will make fats, and excess fat formation in these patients will lead to hyperlipidemia, hypertriglyceridemia, and due to fat deposition, the affected children have round face, which is called doll-like or moon-like face. Okay, round face, right? Then this excess of glucose 6-phosphate will also enter HMP. From HMP, lots of purines are formed. When they are broken down, uric acid will be formed. So this will lead to hyperuricemia. Okay, so what are the clinical features? Severe hypoglycemia, ketosis, hepatomegaly, lactic acidosis, hyperlipidemia, hyperuricemia. So this is the biochemical basis of all these clinical features, right?
So moving on to the treatment of von Wieser's disease. So what is used is, uncooked cornstarch diet is the mainstay of treatment. So uncooked, so the corn flour that is available, so that is a source of, continuous or delayed release of carbohydrate. So uncooked cornstarch diet is the mainstay of dietary therapy for these children. So high carbohydrate, so carbohydrate rich diet needs to be given. Okay, so carbohydrate rich diet. Frequent feeding is required. So you have to feed them at 2-hourly intervals, even through the night, to prevent this hypoglycemic attacks, which can even give rise to seizures. Okay, these children can have severe hypoglycemia, which can be symptomatic and which can have a lot of consequences. Now, apart from that, you will also give management. These children may have osteoporosis and other things, so you have to supplement calcium and vitamin D. They can have, as we already mentioned, Dr. Smily also mentioned, hyperuricemia can be there. So allopurinol may be required for that, okay? Allopurinol may be required, and because of the hyperlipidemia, you may need to give lipid-lowering drugs like HMG-CoA reductase inhibitors may be required, okay? And in severe cases, even liver transplantation is required. So these are so many things that are required in the treatment of von Wieser's disease. So moving on to the last question that we will be discussing here today. So which of the following statements are correct regarding a 3-week child with phenylketonuria? So provocative protein meal tests help in diagnosis. What do you think? Tyrosine becomes an essential amino acid in the diet. Serum phenylalanine is increased and urine phenylpyruvate level is elevated. Phenylalanine should be completely stopped in the diet. So here already it's been mentioned that we are dealing with phenylketonuria. So what do you think should be the answer to this question? Yes, waiting for your reply. Come on. So let us take the options one by one by the time you answer. So provocative meal test, protein meal test can help in diagnosis. So yes, if the diet contains a considerable amount of phenylalanine which the child is not able to digest. So in phenylketonuria, we know phenylalanine hydroxylase is deficient. Okay. So provocative meal test will definitely help in diagnosis and might have to be resorted to in some milder cases. Okay. Tyrosine becomes an essential amino acid. So we know normally tyrosine is not an essential amino acid in our body because it can be synthesized in our body from phenylalanine. But in phenylalanine hydroxylase deficiency, this synthesis or conversion of phenylalanine to tyrosine will not be able to occur. Like Dr. Smily will be telling you in more detail about this. But yes, tyrosine will become an essential amino acid in the diet in this case. And serum phenylalanine level of course will increase because phenylalanine metabolism is not taking place, and urinary phenylpyruvate level will also increase. Now what about the fourth option? Phenylalanine should be completely stopped in the diet. What do you think, friends? So that is true that in this condition, phenylketonuria, the body is not able to digest phenylalanine or not able to convert phenylalanine to tyrosine by the enzyme phenylalanine hydroxylase. Okay, so that is not happening. But you know what is important is we need to remember that phenylalanine is an essential amino acid. So small amounts of phenylalanine are still required by the body, okay, because it cannot be synthesized in the body. So you should not stop phenylalanine in the diet completely, but a low phenylalanine diet needs to be given. So the best answer to this question is, which of these are correct? Only 1, 2, 3 is correct, right? So this is the best answer. Let us discuss a little bit more about the clinical features of this very important disorder. So phenylketonuria, there will be decreased pigmentation in the body. So there can be fair skin because melanin, tyrosine is not getting synthesized, melanin is not getting synthesized. So there will be fair skin, so blonde hair, okay? Even blue iris can be there, okay? Blue iris. And there can be microcephaly, okay, and intellectual disability. So there can be CNS manifestations in the form of microcephaly, intellectual disability, hypertonia, okay, the body tone is increased, and there can be spasticity. So hypertonia and spasticity, and even seizures can be there, tremors can be there, growth restriction, dental enamel changes, and of course you can get a mousy or musty body odor that we already discussed, okay. Dental enamel changes. So over to Dr. Smily to discuss more about the biochemical basis and the pathophysiology of this very important disorder.
So let's do the biochemical reaction of phenylketonuria. Phenylalanine is taken in diet. This is an essential amino acid. But tyrosine can be formed in body from phenylalanine by enzyme phenylalanine hydroxylase. This enzyme requires oxygen, right? So therefore, tyrosine is non-essential in our body. But in phenylketonuria, this enzyme is deficient. So tyrosine becomes essential. Now these patients have to take tyrosine in diet, okay? And because of deficiency of tyrosine, pigment melanin will not be formed because tyrosine forms melanin. So many neurotransmitters like catecholamines, thyroid hormones, which are formed from tyrosine, they are not formed. That's why brain is affected in these patients. Okay. Then, on the other hand, the substrate phenylalanine will accumulate. The substrate will accumulate, leading to the formation of excess phenylpyruvate, phenylactate, and phenylacetate. Okay. This phenylpyruvate coming in urine, phenylpyruvate is a keto acid which is coming in urine. That's why the name of disease, phenylketonuria. Some phenyl ketone is coming in urine. Which phenyl ketone? Phenylpyruvate. Okay. Then, due to phenylacetate coming in urine, this gives mousy or musty odor to these patients, right? Also remember that this enzyme, phenylalanine hydroxylase, requires tetrahydrobiopterin and NADPH. These two coenzymes are required. And these two coenzymes are also required for other two aromatic amino acid hydroxylases, that is tyrosine hydroxylase and tryptophan hydroxylase. Okay, I repeat, tetrahydrobiopterin and NADPH are required for these three hydroxylases, right? Then in diagnosis, we have ferric chloride test, which detects phenyl pyruvate in urine. Then we have DNPH test, that is dinitrophenylhydrazine test, which detect keto acid in urine. Then Guthrie's bacterial inhibition assay, which was earlier used but now it is not used. Then tandem mass spectrometry, which is the best investigation for the confirmatory diagnosis. And in fact, mass spectrometry is the best investigation for any inborn error of metabolism. MS or mass spectrometry is the best, right?
So the treatment of phenylketonuria, so we already mentioned that what you have to give is a low phenylalanine diet. So phenylalanine should not be stopped completely from the diet, but we have to give a low phenylalanine diet, and that has to be followed lifelong. What else can be done? We can also do oral tetrahydrobiopterin supplementation, because tetrahydrobiopterin is a cofactor for this enzyme phenylalanine hydroxylase. So this oral tetrahydrobiopterin supplementation can also help in treating this disorder. So oral tetrahydrobiopterin supplementation. Now apart from that, people have also tried supplementing the large neutral amino acids, because they can also compete with phenylalanine in entering CNS. So that if phenylalanine, the neurological features are happening because of the excess level of phenylalanine that is going to enter the CNS. Now if you give this large neutral amino acids, they can interfere or they can compete with and decrease the entry of phenylalanine into the CNS and can decrease the neurological manifestations as well. So these are some things which are used in the treatment of these very important disorders. So these are some very, very important disorders where both biochemistry and pediatrics need to be studied together in an integrated manner, so that you can understand these disorders better and remember the important points about these disorders, and which you can apply in your exams and in your case scenarios, and you can really have success and come out with flying colors. So keep revising your concepts, okay? Keep working hard, make your basics very strong, try to integrate and study wherever possible, and all the very best for your future exams. May you do very well in your exams, study hard, and you will definitely succeed. Thank you so much.